Welcome to OmegaMatters. I'm Kristina and this is Bill. And today we have the pleasure of chatting with Dr. Dariush Mozaffarian, or Dari. Dr. Mozaffarian received his MD at Columbia University in New York City. He did his internal medicine residency at Stanford and a fellowship in cardiovascular medicine at the University of Washington. It was there that he became interested in public health, receiving an MPH and later a doctorate in public health from Harvard. And in 2006, he joined the faculty at the Harvard Medical School and the School of Public Health. And 8 years later, moved across town to Tufts University, where he's currently the Dean of the Freedman School of Nutrition Science and Policy. He's also a Jean Mayer Professor of Nutrition and a Professor of Medicine at Tufts. And almost 20 years ago, he published his first paper on omega-3 fatty acids and heart disease. And it's this aspect of his career we want to focus on today. So thank you for joining us.
Pleasure. Thank you.
Yeah. So we've already gone into your background. Could you tell us how you got interested in omega-3 fatty acids?
Well, for me, I was always interested in what impacted my patient's health most of all. And it was so clear throughout my training in medical school, in residency and fellowship, all those years of training, 11 years of training, that food was pretty much the biggest factor affecting my patients. If they smoked, probably smoking, but outside that, it was really nutrition. And yet I wasn't learning about it at all in medical school, internal medicine, residency, or cardiology. So that was, kind of a first big epiphany. And then the second big epiphany was when I started reading about the science myself. So at least I would know enough to help work with my patients. I realized that the science of the day wasn't being translated into practice. And so at the time, this was in the 90s, this was at the height of the low-fat diet craze, where everything was low-fat. And after 100 years of Oreos being the top-selling cookie in the United States, Entenmann's, these low-fat, like cardboard-tasting things, like became the top-selling cookie in the United States overnight. And yet, even in the 90s, the dietary guidelines didn't support low-fat diets. They supported high healthy fat diets, kind of Mediterranean-style diets. And so that was a second epiphany that, the top cause of poor health isn't being taught in healthcare. And then second, that the science we have isn't actually being translated into practice. And so those are two things I've tried to do in my career: understand the science better and translate it into practice. And, as I mentioned, given what I had learned about fats, one of the most interesting things to me was healthy fats and how fats were actually healthy, which was not a concept I'd ever heard before. And omega-3s are the perfect example of a healthy fat.
Yeah, absolutely.
Good. Very straightforward. So you really cut your teeth in at Washington, I believe, in epidemiology. You became interested in fat epidemiology and started out with looking at fish as fish intake as related to outcomes. More recently, you've gotten more into biomarkers of omega-3 as they relate to outcomes. Why did you make that transition? Why is that important?
Well, I'll actually go back a little bit to my original interest. The first thing I wanted to do as a fellow was to do a randomized controlled trial of the Mediterranean diet in patients who had survived heart attacks. Do a pilot study of maybe 100 patients, randomize them to a low-fat American Heart Association diet and Mediterranean diet, and just look at compliance and tolerability for 6 months. And I had funding to do that. Somebody heard me speak from a foundation in Seattle and wanted to fund it. So I just needed a faculty member to help me to be the actual PI, since I was a fellow. So I went around and talked to 20, 30 different faculty members at University of Washington, trying to find somebody to be a PI for this Mediterranean diet trial, where we had the protocol and funding. And nobody in medicine was interested in nutrition or Mediterranean diets that I could find. And I was very lucky in that search to come across David Siskovic, who was a professor at the University of Washington and who well, Bill. And David was the first person I talked to. He said, look, I don't have any expertise in Mediterranean diet trials, so I don't think I'm the right person for that. But what do you want to do in your career? What's of interest to you? Like, where do you want to be in a few years? What's your goal? He actually took interest in me as a scientist, as a person, and wanted to help grow my career. And so that's how I got into working with David and the cardiovascular health study, was because I found an amazing mentor. And so I just want to highlight that story first, just to give kudos to David Siskovic and also to give kudos to mentorship. I think for anyone interested in this field, you have to find the right mentor. To get to the second, or to your actual question, which was
good.
focusing on not just dietary self-reported diet, but also biomarkers. I will point out that both are very important and useful. Some people criticize self-reported diet as not providing any useful information, and that's just not true. There's plenty of studies that have looked at self-reported diet against a range of other validated tools showing that they're pretty good. They're not perfect, but they're pretty good. So you get a lot of information. But what you don't get from self-reported diet is the precision of individual molecules, the objectivity of individual molecules in the bloodstream, and also the integration of diet with metabolism, because when we eat foods, we also have a metabolism or microbiome or physiology. And so when you look at biomarkers, you get that. You get the specificity of specific molecules, the objectivity where you're not reliant on recall, and this integration of both what we're putting in our mouths and what happens to it when it enters our body in terms of the ultimate levels in our bloodstream. So it's a very powerful way to look at diet-related risk factors like omega-3s, trans fatty acids, molecules produced by the microbiome, many other things, and risk of various diseases.
Do you see a role for measuring omega-3 levels, particularly in clinical care?
Well, I think we need to integrate nutrition into clinical care in a range of ways. And so, we have shown, my gut feeling when I was in my training has been now confirmed by many quantitative studies that poor nutrition is the top cause of poor health in the United States and the top cause in the world, exceeding every other cause, including actually tobacco smoking. And yet we're not measuring or assessing or reporting on the top cause of poor health in healthcare. So there's nothing in the healthcare system. Doctors don't learn when they're learning their SOAP notes, subjective, objective, assessment plan, how to assess nutrition. It's not in the medical record. And so we need to integrate nutrition. And so I think that should be done in many ways. One of those should be a short kind of nutrition screener or nutrition vital sign, maybe 10 questions that should be asked at every clinical visit. And there should also be a physical activity vital sign. And Kaiser Permanente has actually implemented that. They have a 2-question physical activity vital sign that every patient at every clinical visit gets. We need a nutrition vital sign. And then I think you need an annual nutrition physical. And that annual nutrition physical should include a more comprehensive dietary assessment, like a food frequency questionnaire or some diet records, and a range of biomarker studies that could be done. Not every biomarker study would need to be done every year on every person, but among biomarkers that should be done at least once, you probably want to know a person's omega-3 levels, given how predictive those are for a range of diseases.
Mhm.
Yeah.
Yeah.
Right. Great.
And omega-3s are nice from an RD perspective because food-wise, they have pretty much one source, which is not the case with most other nutrients, actually. So it's pretty easy to capture, just asking a couple questions, capture a pretty good idea of what levels are. And kind of going along this practical path, how do we do this practically? We're kind of interested in what you think about health policy and the current state of omega-3s in the federal nutrition recommendations, and if that's changing or if that's really important actually to moving it in the clinical space, in the medical space. Are those federal recommendations important for omega-3 specifically?
Well, one of the striking things about US food policy is there is no unified US food policy. So there's no single set of recommendations. There's actually fractured policies and programs. And so just as 2 examples, you have the dietary guidelines for Americans, which are put out by the Departments of Health and Human Services and Agriculture jointly every 5 years. That determines school meals, standards for school meals, a range of other things, and kind of the public guidelines. Then you have what's on the back of packages, the nutrition facts information. That's not determined by the dietary guidelines. It has nothing to do with the dietary guidelines. That's determined by the dietary reference intakes, which are set through a totally separate process, often by the Food and Drug Administration in collaboration with the National Academies of Medicine, and often with actually multiple governments. And those, in contrast to the dietary guidelines that are updated every 5 years, don't have any statutory updating or guidelines. And so back to good old fats, the last time the dietary reference intakes, the DRIs, were updated for fats, carbohydrate, protein, and energy was 2002, 20 years ago. So everything we have on the back of the packages, all those percentages are based on at least 20-year-old science, if not 30 and 40-year-old science. And nothing we've learned in the last 20 years is actually being passed on to nutrition. I will say that Tufts was involved with Congress a few years ago raising these issues, and Congresswoman Rosa DeLauro and Congressman Tim Ryan instructed the Government Accountability Office, the GAO, which is the US government watchdog, to audit federal food policy around nutrition and diet-related chronic disease. And that report came out in September of 2021. It's a terrific report. And what the report concluded is there are 200 different federal policy efforts intending to improve nutrition. They're fractured and fragmented and not harmonized. Two of them I just mentioned. There's 198 more. And that lack of coordination is causing significant inefficiencies and failure to meet the government's goals. And the GAO instructed Congress to create or instruct a federal entity to coordinate federal food policy. And so Congress is looking at those recommendations, that audit, and thinking about how to coordinate federal food policy. So that's the big picture of there is no single federal policy around omega-3s, but there's at least two things. There's the dietary guidelines and there's the dietary reference intakes, which guides what's on the back of the package. The dietary guidelines have moved forward every time and with more and more stronger evidence recommending fish as part of a healthy diet. And the latest dietary guidelines recommended, at least 2 servings per day. The dietary guidelines can't set a DRI. They can't set the percentage intake or gram intake. That's a separate process. And so that requires the US government, usually again, to get together with some other governments, particularly Canada, to ask the National Academies of Medicine to set a new DRI. That can cost a couple of $1 million, take a couple of years. I really think it's time for that to happen for omega-3s. There's enough evidence that I think the US government could set a DRI and allow an amount to be on the back of the package. And at least 10 years ago, I worked with the World Health Organization and United Nations Food and Agricultural Organization, and we sort of did the equivalent process. They're not called DRIs, but we basically set adequate intakes for omega-3s with a scientific panel that was released and published by the UN Food and Agricultural Organization, the United Nations. And there, we did recommend 250 milligrams of EPA and DHA for every adult and a size appropriate amount for children. And for women who are pregnant or nursing or may become pregnant and nursing, in addition, a minimum 200 milligrams of DHA. So I think that's a pretty reasonable recommendation that if there were a DRI, maybe should be mirrored in the United States.
Mm-hmm. And what does that translate to in fish intake, that amount?
Well, so fish, it depends on the fish, as you know. So, there's over 1,000-fold difference in omega-3 content between different types of fish. And so, white flaky fish tend to be the lowest in omega-3s. Fish like cod and pollock, that's kind of what's common in fish and chips, tend to be very, very low. They still have more than most other foods, so they're still a good source, but they tend to be low. And then, trout and bass and shellfish tend to be kind of medium. And then the oily and dark meat fish like salmon and ahi tuna and
like herring and sardines.
Herring, sardines tend to be very high. So if you're eating oily fish, 1 or 2 servings a week, 1 serving a week even could get you that.
Mm-hmm.
If you're eating a super white fish, maybe a serving, 5 servings or even a serving a day. 5 servings or even a serving a day.
Yeah. And that's really matches with the dietary guidelines too, from what I've seen. Those are the same. Mm-hmm. Yeah.
Jumping over more into the clinical side, your thoughts about whether, like the AHA, the ACC, will ever recommend omega-3 supplements or higher intake of omega-3 for reducing risk for heart disease?
Well, I've been, fortunate to be part of some American Heart Association statements on omega-3s and on fish and seafood, and the American Heart Association's dietary guidelines do certainly recommend fish intake. Yeah. And the challenge with, I think we were moving toward a strong recommendation for supplements with, trials, in the last 20 years, several positive trials showing benefits of omega-3s for cardiovascular disease. But then several trials have been published that haven't shown benefits for supplements. And this is a really perplexing area because, out of about, like, say, 15 or 18 major trials, about half have shown benefit and about half haven't. And they're all reasonably well done in different ways. You can't find any obvious, methods differences that might explain these results, or population differences that might explain these results. And so I think it's still perplexing. But I will say that fish oil supplements are the only supplement full stop that have ever been shown to have a hard clinical benefit in a clinical trial. So vitamin C, vitamin E, vitamin D, I mean, everybody's on vitamin D, calcium, the vast majority of these vitamins and nutrients have never been shown to have a significant health benefit, except maybe in very selected populations who are deficient and truly clinically deficient. So there are at least some trials, some very well done large trials that do show significant benefits of fish oil. So I don't know what the American Heart or American College of Cardiology will do. I think they'll need to see probably more robust and consistent trials. But what I recommend to patients is to eat fish, 2 servings per week, preferably oily or dark meat fish, which is higher in omega-3s. And if you don't eat fish, or if you eat fish but want to be sure to get your omega-3s, perfectly reasonable to take a supplement, a supplement once per day. We know very, very well there's absolutely no harm, and it could benefit you.
Yeah. Do you see any large trials like Strength or Reduce It in the future?
Well, these were 2 large trials that were done, and very similar designs, very similar treatments. I mean, one was EPA only, one was EPA and DHA, but I don't think that explains any differences. And one showed benefits and one didn't, and it's perplexing. There's lots of theoretical reasons for this, but the Reduce It trial, which showed benefit, used a mineral oil placebo, and in the placebo group, ApoB and LDL cholesterol went up, and CRP went up, which had never been seen in any other trial, suggesting that the mineral placebo could have actually had some harms. On the other hand, even if you account for those changes, it doesn't look like it would totally explain the benefit. So probably there still was benefit of the Reduce It. The Strength trial, I was on the steering committee of the Strength trial. By every indication should have shown benefit and didn't. And that could just be chance, right? We have confidence intervals, we have random chance in science, maybe just statistically by chance it didn't show benefit. We can't exclude that. So I guess the question is, who's going to step up now and invest, the significant funds to test either of those agents? Probably no one. But if another agent comes up that's a different formulation or has something maybe more attractive, I think the market is quite large for natural treatments that address residual lipid risk, like high triglyceride levels.
Yeah. So it's either going to be another drug company or it's going to be the NIH.
Well, so you've opened the perfect door for me to talk about one of our policy advocacy topics, which we've been working on for a couple of years, is advocating for a National Institute of Nutrition at NIH. So just like nutrition is missing in healthcare, the top cause of poor health is missing in healthcare, the top cause of poor health is not focused upon in our National Institutes of Health. And so the National Institutes of Health is the world's premier research organization. It's terrific, has amazing research, does so much good. And yet it's 27 centers and institutes. None of them have a core focus on nutrition. So it's time for a full institute to have a focus on nutrition. I think if there were an institute with sufficient new funding to have focus on that, we could get funding for a major trial like that.
Great.
Yeah.
And where are we at? You got the National Institute for Nutrition established? Is it happening?
Well, so it would take an act of Congress, and the last time a new institute was put in, I think was about 20 years ago, and I think it was Senator Tom Harkin who did that, and he's very supportive of this effort as well. We have spoken to him many times. So that takes an act of Congress and means political will to make it happen. At the same time, NIH has actions that they can do to build nutrition research, and they have heeded the call from the community, from Tufts and others in the community. And so two things that have happened at NIH, which NIH could do without Congress, is they've created a new Office of Nutrition Research in the Office of the Director at NIH that was created last year. And that was really important because there's a handful of offices, specific offices in the Office of the Director that then coordinate research across NIH. And so every dollar spent in those offices can have a manifold benefit in coordinating research across NIH. And so having a new Office of Nutrition in the Office of the Director is really important. And then it was created last year as a new office. It didn't have much of a budget. It had $1 million budget, which isn't, terrific. In the president's budget, which just came out a couple of weeks ago for next year, they proposed that office have a $97 million budget. So an increase from 1 million to 97 million. That's a pretty good increase. And with a $100 million budget, the office could have some really significant impact. And so if that budget is approved by Congress, that would be terrific. And then secondly, the NIH has released a strategic plan for nutrition research last year, and also a precision nutrition initiative, a major funding for precision nutrition. And so I think NIH, to the extent it can without Congress, is definitely listening and understanding the importance of nutrition science.
Do
Great.
you
Great.
see
Well, that's good news.
a partner like Department of Nutrition on the food side when you get out of the research side? Because we have USDA and FDA that kind of are governing the food side. Do you see a need for that to be streamlined as well?
Well, so I think first, the National Institute of Nutrition would have many positives. It would be within Health and Human Services. NIH is within Health and Human Services. It would have many positives beyond research. It could coordinate cross agency research. It can coordinate research with USDA, with the Department of Education, with the Department of Defense, with the VA Health Services, with the CDC within Health and Human Services, with FDA within Health and Human Services. All those agencies do nutrition surveillance and research. And so the National Institute of Nutrition could do that. It could also help create an organized curricula for healthcare professionals to learn nutrition in their training. The NIH has a lot of funding and support for nutrition training, for training of research and healthcare professionals. They could organize that. Third, I mentioned earlier that dietary guidelines come out of both USDA and Health and Human Services. Health and Human Services doesn't have a huge budget or staff to be that partner, although they do a great job with what they have. The National Institute of Nutrition could be a part of a partnership for the dietary guidelines, which would be terrific. And then lastly, the dietary guidelines by statute are for the healthy general population. They're not for disease populations. Mm-hmm. So we have no national guidelines for diabetes. We have no national guide for nutrition for diabetes, national guidelines for hypertension, no national guidelines for obesity. And those patient populations get upset every time the dietary guidelines come out. They say, there's nothing in here for me. That's by law. The dietary guidelines are not for the disease population. Health and Human Services is supposed to do those. It's supposed to do the guidelines for the disease population. It's the National Institute of Nutrition could do that. I think for larger coordination, for broader coordination, what we've proposed is a new Office of the National Director of Food and Nutrition in the White House. This is building on the model and the precedent of the Office of the Director of National Intelligence. And so that was created in 2003, 2 years after September 11th, when Congress did an inquiry and recognized that one of the reasons there was the terrorist attack and it went undetected and was able to happen was lack of coordination among the federal investments in national security. And so they created the Office of the Director of National Intelligence to coordinate national security, and it's overwhelmingly been a success. It's worked really, really well. The office works with the FBI and the CIA and the National Security Council, and assists with the cabinet. And our investments, our federal investments in food and nutrition far exceed our federal investments in national security by manyfold. And costs of poor nutrition far exceed, actually the cost of wars and other things. If you just look at the number of Americans dying every month from poor nutrition, it exceeds all the Americans that died in the Iraq and Afghani war combined. And so I think there's clear need to have a similar office that coordinates federal food and nutrition policy.
Yeah, I think that's a great idea.
Great stuff. Great stuff. Dari, thank you very much. I know we got a hard stop here coming. So we will let you go and appreciate your comments and thoughts, and look forward to maybe talking to you again.
Yeah, terrific. And it's so nice to speak with you, and for, to you, Bill, who've done so much work to advance knowledge and attention on omega-3s and their really pretty incredible physiologic effects on a range of pathways and their potential benefits for cardiovascular disease and other diseases. You've really shined a spotlight on that. And I think that, we're still halfway through the journey, the omega-3 story, and there's more to learn.
Good. So there's something for my daughter to learn then, huh?
Oh boy.
Thanks, Dari.
All right. Thank
Take
you.
care.